Imagine a pregnant woman comes to you with the complaints of severe headache, blurred vision, and swelling of her face and hands. And a doctor checks her BP and it was around 160 bar 110 mmHg. Hello everyone. Today we will discuss about the preeclampsia. Preeclampsia. It is a pregnancy-related hypertensive disorder. It usually occurs after 20 weeks of pregnancy and it can also affect the multiple organs like kidney, liver, and brain. If you left untreated, it may lead to the seizure. The exact cause is unknown, but it is believed to start in the placenta when the blood vessels are not developed properly. It leads to the reduced blood flow to the placenta. The common risk factors include preeclampsia in the previous pregnancy, chronic high blood pressure, and diabetes or kidney diseases, being pregnant with a multiple twins or autoimmune disorders like lupus, and being pregnant after the 30 years of age or before 20 years of age. The common symptoms of preeclampsia include severe headache and vision changes, sudden swelling in the hands and face, and upper abdominal pain that indicates there is a liver involvement is there, and shortness of breath caused by fluid buildup in the lungs. The patient is diagnosed based on the hypertension that is more than 140 bar 90 mmHg, and you have to take the at least two readings 4 hours apart, or else if the BP is more than 160 bar 110 mmHg, one reading is enough. Along with the high blood pressure, at least one severe feature should be there. Either that may be a proteinuria that is more than 300 mg per 24 hours of urine, or protein creatinine ratio greater than 0.3, or dipstick test more than 1 plus. If the protein is absent in the urine, to confirm the diagnosis, at least one severe feature should be there. That may be a thrombocytopenia, platelet count is less than 1 lakh per microliter, or impaired liver function, renal insufficiency, where the serum creatinine level is more than 1.1 mg per dl, and pulmonary edema due to the fluid buildup in the lungs, and the neurological symptoms like headache and visual symptoms. Oliguria, if the urine output is less than 500 ml per 24 hours, or fetal growth restriction, or persistent symptoms like symptoms not relieved by with the medication. Here the key point is the preeclampsia is diagnosed after the 20 weeks of gestation. Severe features anyone is enough to classify the severe disease. The treatment goal for the preeclampsia include prevent the complications like seizure, stroke, organ damage, and maternal death. Control the BP less than 160 bar 110 and to reduce the risk of complications. Ensure maternal well-being, relieve the symptoms, and maintain the organ dysfunction. Ensure fetal growth well-being and prevent the preterm complications. Plan timely delivery, deliver at the appropriate time for the best outcome for mother and a baby. To control the blood pressure in the preeclampsia, starts with the antihypertensive drugs. The target BP is 140 to 150 bar 90 to 100 mmHg, and do not lower too much to avoid the uteroplacental hypoperfusion. The first line medications include labetalol, nifedipine, and hydralazine. Labetalol, give the 20 mg through the IV route, then 40 mg after 10 minutes, then 80 mg every 10 minutes. Maximum you can give the 300 mg, or give the 100 to 200 mg per oral 2 times a day. And this labetalol is safe during the pregnancy, and it is an alpha plus beta blocker. It is a first choice during the preeclampsia to control the blood pressure. If the labetalol is not available or the patient has asthma, in that condition, you should give the nifedipine as a first choice. 10 mg per oral, repeat after 20 to 30 minutes, and maximum you can give the 30 mg. Then 10 to 20 mg every 6 to 8 hours to the oral route, and it's a good alternative, especially if there is a no IV access. And if the both the drugs are not available, go with the hydralazine, that is 5 to 10 mg through the IV route, repeat every 20 to 40 minutes. Maximum you can give the 20 mg or 10 to 25 mg through the intramuscular. Avoid ACE inhibitors and ARBs because this causes the fetal toxicity. To control the seizure during the pregnancy, the drug of choice is magnesium sulfate. The loading dose is 4 to 6 grams through IV over 15 to 20 minutes, and maintain with a dose of 1 to 2 grams per hour through the IV infusion throughout the labor and 24 hours postpartum or until risk of seizure passes. Monitor for the magnesium toxicity, check for the loss of tendon reflexes and a respiratory rate that is less than 12 breaths per minute, or if the urine output is less than 25 to 30 ml per hour, or decrease the level of consciousness. If any of the symptoms are present, means give the calcium gluconate as an antidote. That is 10 ml of 10% IV over 10 minutes. Do not give the magnesium sulfate with a patient with a renal failure, myasthenia gravis, and heart plaque. Give the benzodiazepines as your first line to prevent the seizure. And delivery is the only definitive cure for the preeclampsia. If the delivery period is more than 34 weeks with a severe preeclampsia, do the delivery. Or else any gestational age with a eclampsia, vital distress, placental abortion, and pulmonary edema or uncontrolled severe hypertension. Oliguria and the liver failure is there, means do the delivery immediately. Or if the pregnancy period is less than 34 weeks, means stabilize the mother and give the corticosteroid drugs, because these corticosteroids matures the baby's lung. And examples like betamethasone 12 mg intramuscularly every 24 hours for 2 days, or dexamethasone 6 mg through the IV or intramuscular route every 12 hours for 4 doses. Close maternal and fetal monitoring should be done, and deliver if maternal and fetal condition worsens. The mode of delivery is vaginal delivery preferred. If the mother is unstable, go with a cesarean. Here, the delivery is the only definitive treatment for the preeclampsia. Supportive management of preeclampsia. Restrict the sodium intake and maintain the fluid balance, and monitor for the CBC to check the platelet count and liver function test, renal function test, uric acid level, and electrolytes, coagulation profile, and urine protein. Treat the complications like pulmonary edema, ELPA syndrome, and DIC. And in the postpartum, continue the magnesium sulfate and antihypertensive drugs for 24 hours or longer if needed, because the BP may worsen after delivery. So close monitoring should be done. Untreated preeclampsia can lead to serious complications for both mother and baby. That would be a fetal growth restriction, where the baby does not grow as expected, preterm birth, where the baby is delivered before 37 weeks of pregnancy, and placental abortion, where the placenta separates from the uterus prematurely. And the untreated preeclampsia can develop into the eclampsia and ELPA syndrome,